This is a special edition of the CardioCast by MDedge. I'm the voice of MDedge Podcasts, Nick Andrews. Welcome to this special edition of the CardioCast. In this edition, we bring you part 2 of our Reporters Roundup conversation from the 2019 Annual Congress of the European Society of Cardiology. This conversation is led by MDedge Cardiology editor Catherine Hackett. She's joined by reporters Mitchel L. Zoler, Bruce Jancin, and Kari Oakes. Today, their focus is on practice-changing studies for preventative medicine. Here now, Catherine Hackett, Mitch Zoler, Bruce Jancin, and Kari Oakes.
Well, let's move on to prevention, because there were a lot of very big and very important studies related to prevention, related to nutrition, related to an investigational drug that is pretty exciting. So why don't we go first to the PURE study, which there are several reports. And Kari? Okay.
Do you want to start again?
Why don't we... No.
Put your phones on mute.
Yeah.
I'm going to check.
I'm trying to turn down my phone, but I just can't.
No.
This will be nothing, but that'll happen again.
Well, no, you've got a clicker here on the side.
Oh, that's right, yeah.
Just turn it off. And
Yeah, okay.
It'll vibrate.
Okay. So let's turn our attention to the huge prevention studies, and one is a McMaster University Salim Yusuf study called PURE, which we've been reporting on for 2 years, and they've got some very interesting analyses now. And Kari covered 2 of them, and Mitch covered 1 of them. So Kari, why don't you tell us what you can about it?
Well, I think I think the first thing about PURE to know is that the United States is not included in the PURE study. It's a study of what are sometimes called high, middle, and low-income countries, or high, medium, and low-resource countries around the world, looking at all kinds of outcomes with hundreds of thousands of people enrolled. Canada is included in the PURE study. Canada is where McMaster University is located, but the United States is not. Having said that, it was clear that there is some shifting patterns that probably are going to be applying to people in the United States as they take care of patients over the next decade. From Dr. Yusuf's talk about high-level findings from PURE, perhaps the most striking was this shift in patterns, so that cardiovascular death is now less common than death from cancer in the high-income countries that were included in the PURE study. And there was a little bit of a stunned silence when people saw those slides. But it was very clear, and you very much see that in the medium resource countries that were included, that it's sort of 50-50, maybe not quite. And it's in the low resource countries that there is still an imbalance of deaths from cardiovascular causes. Now, Dr. Yusuf said, in discussing with a bunch of us after the press conference, he drew a few little kind of impromptu graphs and said it's really not that cancers are increasing. He drew a fairly, there was a modest slope to that line. He said that cardiovascular deaths are really dropping in the developed world, and that it is partly prevention, primary prevention and secondary prevention, but really it's treatment. It's the interventions that we're able to achieve that are making the difference.
And I'm pretty sure that's going on in the U.S. now as well.
I think so too.
I'm fairly sure I've seen reports and meetings over the past few years of cardiovascular disease deaths getting below cancer in the U.S.
Yeah, exactly. An interesting point that he made, interesting to me at least, was that there are some countries that have just sort of newly nudged into the high-income category. Examples of these are some of the more economically successful South American nations. Poland, for example, is a nation that now is categorized as high income, but they still face a lot of a wide socioeconomic spread. They have a large proportion of poor people, and there may be lifestyle practices that are sort of a holdover from earlier years when they were under a different regime that still affect how people live and the resources they have.
And I think it was also interesting to me the point he made about some of the factors that seem to be contributing to the higher cardiovascular disease death rate in the middle and low income countries. Yeah. One he particularly stressed was indoor pollution. And I've been reading about that of homes where you have some kind of cooking and heating fire right in the home, and you have all these products of having open fires that fill the air in that household. And you can imagine that there's a lot of stuff getting into people's lungs and their blood and all kinds of things.
Correct. Yeah, he said he was surprised to see the effect to which pollution contributes. And they're looking at both ambient pollution, and they can track that to a fairly small footprint on the ground, evidently, what particulate matter looks like in many parts of the world. But yeah, indoor pollution, he presumes mostly from whatever you use to create heat to cook with. If it has particles associated with it, you're going to be breathing it. And that has a heavier burden than they'd realized. You know,
I didn't cover any of these, but I just noticed in the program that there were other reports as well about pollution, outdoor pollution as well, and associations with various kinds of spikes in cardiovascular disease. So it seems like increasing attention is being paid to that as a risk factor.
In Japan and Korea, they call it the golden wind.
Oof.
It comes from the Gobi Desert in the interior of China seasonally. And you get up one morning and there's an eighth of an inch thick coat of fine dust everywhere. And that's the part that settles on the ground, but the part that's been able to be airborne for 600 or 1,000 miles is really small particles.
And it's as you mentioned, Mitch, the contributors to mortality in different parts of the world are not what some people might think they were. And Dr. Yusuf broadly differentiated things that individuals can change. So things that prevention strategies like stopping smoking is an individual strategy, but there are things like pollution that an individual can't change. An interesting aspect of that, and maybe you want to start talking about that now, was the dietary information that they're collecting in Pure.
Well, it was, I just in the analysis that you're talking about, Kari, he pointed out that a poor diet is another significant contributor to the analysis, but he made the point that it wasn't poor in the sense necessarily you think like high fat. He mentioned higher fat in the diet actually is protective, but other aspects, kind of the junk food aspect, I believe, or the high salt perhaps he was referring to, but diet definitely is a big contributor. And the part of the Pure results that I covered was their analysis of BMI and waist to hip circumference and grip strength. But the finding in that analysis that really struck me was the BMI and mortality link was the lowest, both overall mortality as well as cardiovascular death mortality was in the people, particularly men and women, with a BMI of 27, and more broadly, people in the category of a BMI of 25 to 30, which, of course, is called overweight currently, and normal weight is a BMI of 20 to 25. And I particularly asked Professor Yusuf if that observation applies to high-income countries such as Canada and the U.S., and he said absolutely it does. That he told me that this is not a new finding and that it's been largely ignored or dismissed by people who do things like set what the target BMI rate should be, and that they've pretty much been ignoring the evidence coming out that if you assess a good body weight in terms of how long people will survive with it, it actually is in that overweight category.
Yeah, I thought it was really interesting too, and I think I heard some of that conversation. And actually, I think Dr. Youssef did make the point that salt consumption contributed very little to the global deaths that they saw. He said that salt has been overrated as a contributor.
Which was very interesting. I know you'll get to in a few minutes say another study on salt, and it just shows the complexity of trying to make head or tail of nutrition and
health.
health.
Salt study too that really makes you think about everything. But so in particular, Dr. Youssef said they have trialed a bunch of different ways of looking at strength, health, fitness, and BMI. He said BMI isn't good. They've tried, grip strength with a dynamometer is a crude measure of some level of overall muscle strength, and it's easy to do. And he said, basically, if you can grip half your body weight, you're doing well. If you can grip a quarter or less of your body weight, you're not fit. And so that gets at measures of both body mass and muscle mass in one crude measure, which is kind of great for the kind of research he's doing. But he also said, full-fat dairy, good. Moderate amounts of red meat, good. Not 3 steaks a day, but a little bit of red meat, good.
Well, you need something to get you in that 25 to 30 range.
Well, I went to 3 different presentations on different studies that make that same point, that the optimal body weight is overweight, BMI 25 to 30. Just very briefly, there's the Scandinavian Stability Trial, a prospective study, nearly 16,000 patients, stable coronary heart disease on optimal medical therapy for 3 to 5 years of prospective follow-up. There's a J-shaped curve for major adverse cardiovascular events in terms of BMI, with the lowest incidence at 25 or 30. The Global Leaders study is about 16,000 patient prospective study of recipients of a drug-eluting stent on randomized to a couple different antiplatelet regimens. And the obese and overweight patients had a lower 2-year all-cause mortality than the normal or healthy weight patients, again with the J-shaped curve. And in the Malmo diet cancer study, which is a huge study with like 28,000 Malmoites followed prospectively for 20 years. They looked specifically at 3,800 obese subjects and divided them into 2 groups. 1,200 roughly were metabolically healthy, which meant that they'd never been to the hospital except to give birth or because of injury. And they when they compared them to all of the non-obese people in the whole study, which is a much larger group, they had basically the same all-cause and cardiovascular morbidity over time. And compared to the metabolically unhealthy obese, they had 26% lower all-cause mortality, 31% lower cardiovascular morbidity. So it seems like fit but fat. That's the new thing. It's real.
Fit but solid.
Overweight.
Fit but solid, maybe.
Yeah. Any of the prevention studies?
Oh, sure. I got to.
Well, I could talk about the 2 salt studies.
Do.
Okay.
Yeah.
Please do.
Okay.
I've got a secondary prevention study we'll talk about later.
Okay.
Okay, I'll start with Kari. You covered 2 community-based studies on salt that both created kind of a buzz at the meeting, particularly one done in South America. Why don't you tell us about that?
Sure. So Jaime Miranda is a researcher and physician who works at the Academic Medical Center in Lima, Peru. And he, working together with a bunch of people who got a grant from NHLBI, trialed a community-wide strategy to reduce sodium consumption in 6 small villages in really rural Peru. This is at the far northern end of the country. And in all, among these 6 villages, they wound up enrolling just under 2,400 people. So what they did was that they borrowed a bunch of principles from social marketing. So they basically made themselves a small business that took regular salt and replaced it with salt that was 25% potassium chloride, 75% sodium chloride. And they did this by taste testing with residents of this area the amount of potassium chloride they could tolerate without it tasting too bitter or acrid for them. So this was a palatable product. They got a brand, they got a spokeswoman, they hired a local actress, her name was Liz, L-I-Z, and they packaged it, and they hired salespeople to go out and talk to street vendors, grocery stores, housewives, and they were going to replace all of the salt. And so they had a transaction that didn't involve money because they gave the salt away. What they did was they asked people to bring in all their household salt or their salt from the restaurant, and they replaced it gram for gram with this replacement. So they included basically everybody in the village who was eligible, who were adults, unless you had some reason not to have a lot of potassium in your diet, for example, if you had chronic renal failure. And they followed these people month by month by month by month, and at the end of the study period, they found that from the relatively low initial baseline of like 113 systolic, they had dropped a significant 2-ish points, which doesn't sound like much, but from a community-wide level, that's significant in terms of prevention. In terms of incident hypertension, new hypertension cases, they cut that in half. And an interesting point that Dr. Miranda made was that not only did they make a difference, sort of move the needle on a population level, as you would expect this intervention to do, but they included people who had hypertension with diastolic blood pressure over 140. They reduced blood pressure more in those people than they did in the general population. So he made the point that this is a population health measure that's also a medical intervention for people with a known condition. 2 caveats. Well, the interesting one is that they did 24-hour urine collection in a subset of participants, just 100 people, because 24-hour urine collection is a giant pain in the neck. I don't know if you've ever done it or had a friend who's done it. You carry a bottle around all day long. So if you go out to lunch, you bring your bottle with you. So it's a problem to get it done. But at the end of the 24 hours, when they looked at sodium and potassium excretion, the sodium excretion actually didn't really fall significantly in these people. And they don't know if it was a problem with adherence to the 24-hour collection or measurement, or whether people were still using other condiments that contained a lot of salt, or whether they really kept a few jars of salt at home because they like their food salty. However, potassium excretion did go up significantly. And so there were questions asked that Dr. Miranda didn't really want to tackle, having to do with whether the known sort of beneficial effects of potassium on blood pressure may have also played into this. So, I don't know if everyone in attendance was going to go home and fix up what they have in their salt shaker, but it got a lot of attention, and also for being a really innovative design. The other caveat I was going to mention quickly is how to implement this in other areas. You can't really go into Paris and, have all the shopkeepers turn in their salt. Yeah. But the advantages of the social marketing and really taking seriously that you have to sell this is something people want to do is a real thing.
Maybe if you could find some seawater that is 25% potassium.
Exactly.
That would do it.
Yeah, exactly. And there was another one, Hope 4.
Hope 4 was also done out of McMaster University, and I think also out of Dr. Yusuf's group broadly. And this was an intervention that was actually trialed in Canada, in suburban Vancouver and a little further out, and they used firefighters initially to be community health workers to do a broad-based intervention to work on lipid and blood pressure lowering. And the pillars of the intervention were that they trained community health workers. They used other community health workers when they went to their sites in Asia, in the Asia Pacific region, and in South America, who were already doing things like working on birth control, population health, women's health. They gave them a week crash course in blood pressure and lipid management. They were already known to the community. These people, workers went out and worked with people in the community to get the people who needed them their statins and their blood pressure medications. These were made available free and dispensed in larger amounts than usual. They didn't have to come back every 4 weeks. And they did community education, and they also, very importantly, said Dr. Schwalm, who presented this, involved friends and family members. And so this sort of broad-based strategy was really, really good at getting people's blood pressure down and getting their LDL-C down. It was really good at that, suggesting that if you can get medication to people for free, help them understand why they have to take it, they'll take it, and they'll do much better in terms of those outcomes. But interestingly, these people who were connected in the community and working with people who were motivated to take their medication were not able to move the needle in terms of other lifestyle things like more exercise, smoking cessation, things like that. So with that small caveat notwithstanding, the study was also really well received. And a point that Dr. Schwalm made, and perhaps it's easier for him to make coming from Canada, is that you don't have to have a fellowship-trained cardiologist to get somebody to take their lipid-lowering medication, and arguably you shouldn't have that person be the one who's mostly working on that. That the involvement of community health workers, non-physician health workers is the term that we heard, and bringing family members in was really vital in this situation.
Well, adherence is just such a seemingly unsolvable problem sometimes.
It is a problem.
And look how much effort it takes just to get people to take their medicine.
It's a bunch of things. Sometimes it's money. Sometimes it's you can't leave the house. Sometimes you're just a forgetful soul and you're not going to get your prescription filled, so you're missing a week out of a month. And this, removed the price barrier, but also thought a lot about delivering what people need to where they can actually use it.
Right. It's almost like it won't happen here anytime soon, but like the poly pill that were just results, I think, in Iran, but with the poly pill, how well it works. Right. And it comes out once in a while, but it just seems like that's not in the near future in the United States.
Not in the near future, but it's just percolating along.
Yeah.
This is really like turning a battleship. But for sure, in terms of adherence, a once daily drug is always going to be better.
Well, I heard a talk about something that very nicely addresses the issue of adherence in drugs lowering cholesterol. It was about the study was Orion 11, and the drug is inclisiran, which is a small interfering RNA molecule that's packaged into liposomes. And the idea behind this lipid-lowering drug is it works to some extent the same way that the PCSK9 monoclonal antibodies that in the past couple of years or so have really revolutionized the field of lipid lowering and given clinicians another way to approach it, a very effective and potent way above and beyond statins. But unlike the antibodies, the RNA molecule is an antisense to a portion of the messenger RNA molecule that produces the PCSK9 enzyme. And just to make it clear why that's important, that enzyme is involved in the cycling or not cycling of LDL receptors on the surface of hepatocytes, which is where they take LDL cholesterol out of the circulation. And if you inhibit PCSK9, the protein, there is less of this recycling, and the receptor stays on the surface of the hepatocyte, and so there's an ability to take more LDL out of the circulation. So the RNA is in the lipid particles, very small lipid particles, and this gets injected after the first couple of injections, which are given 90 days apart. They are then given 6 months apart. And once it's a subcutaneous injection, and once in the blood, because it's a lipid particle, it goes to the liver and is taken up by the hepatocytes. And inside those cells, it releases the RNA, which then binds to its antisense to the mRNA for the protein, PCSK9. So they bind, and then when a cell sees double-stranded RNA, which usually cells don't like, it cleaves the messenger RNA, and so the end result is less PCSK9 gets made. And it has this study involved 1,600 patients a phase 3 study where they were randomized to get the inclisiran or placebo on top of their the lipid-lowering drugs they were already on. And the patients who got the inclisiran had a 50% reduction in their LDL level that persisted throughout once they got started on this protocol after they had their first 2 injections. That's when the study started keeping track of their LDL level, and they were tracked for the next 15 months. They received over that period 2 additional injections spaced 6 months apart. And throughout that entire 15-month period, their lipid levels were 50% lower than they were at baseline, on top of any other treatment they were getting. So it seems very effective. It was extremely safe. One of the concerns about this class of drug, the small interfering RNA molecules, which, by the way, it's called siRNA, is siRNA with siRNA. And they're now in advanced generations of these kinds of molecules. Initially, they were having problems with very severe reactions at the injection site. Thrombocytopenia was a problem. And there were other issues, safety issues as well, but apparently those have been pretty much resolved with some engineering of the molecules. The FDA actually approved the first siRNA drug a little over a year ago, and I've been told that a few more have gone on the market since then. But this one, there are 2 other phase 3 studies that are using lipid lowering as the endpoint, and those results are expected before the end of the year. And once that data is all together, the company is expecting, again, in the last quarter of 2019 to file with the FDA, which would, the FDA has already established the precedent for lipid-lowering drugs, that because it's so clear the tight relationship between LDL levels and cardiovascular disease risk and occurrences, that the FDA has approved drugs like the PCSK9 antibodies based only on their lipid-lowering effects. There is a 15,000 patient clinical endpoint trial of inclisiran going on now, but the results for that are not expected until 2024. But the expectation is that as long as the safety from these other 2 phase 3 trials is consistent with the first one, that this drug will likely get approval sometime, say, in 2020. And this mechanism of delivery, of giving a subcutaneous injection to a person twice a year, and then once they have that in them, which obviously the clinician administering it knows that the person received it, they're covered, and they don't have to worry about taking pills. They may still have to take pills because it's not like they're going to be ready. The cardiology community and the medical community is not ready to give up on statins, but this would be another dimension to how you can lower lipids, and in a very potent and apparently safe way. So it's something to look forward to. And one other thing on lipid targets that I covered that was very notable to me is the ESC came out concurrent with this meeting with, I think it was a half dozen practice guideline statements, and one of them was a revision of their cholesterol treatment and with targets, and they have now set, the ESC, a new goal for very high-risk patients in a secondary prevention patients who already have either established cardiovascular disease or risk equivalents, that in that population you should have a target LDL level of less than 55 milligrams per deciliter, which is the first time that a medical society has set a target that low for LDL levels. The U.S. came out, the American Heart Association, American College of Cardiology came out with a revision to their cholesterol guideline in November of last year, so almost a year ago. And what was striking to me is, despite a huge amount of accumulating evidence that when it comes to LDL cholesterol, lower is better, they retained the target as 70 milligrams per deciliter. And so for the ESC to now take the next step and move to a lower target, I think is pretty significant. And one other thing about that, I was looking in, so who is exactly a very high-risk patient? So, as I said, people with established cardiovascular disease, people with familial hypercholesterolemia, people with severe chronic kidney disease, a GFR of less than 30 milliliters per minute, people with diabetes and target organ damage. But another population that the ESC identified is people with, they don't use Framingham risk score, they use something that is called simply SCORE. It's an acronym, and I don't recall offhand what it stands for, but people with a score of 10% or more, which means they have a 10-year risk, a 10% 10-year risk of a fatal cardiovascular event happening, or 1% per year. And in their guideline, the ESC put in, I guess this is their most updated version of the SCORE table. To calculate a person's score, you use their cholesterol level, their systolic blood pressure, their sex, whether they're a smoker or not, and then the region of Europe that they live in. And in even the lower risk region of Europe, I know the high risk is generally Eastern Europe and the low risk region is generally Western Europe. Men who are 70 and older, regardless of whether or not a smoker, all smokers, male smokers more than 70 are very high risk, regardless of blood pressure, regardless of cholesterol level. Most non-smoking men, 70 and older, even in a low-risk region, are very high risk, and a smattering of women as well. So age is a really big driver of risk, and you really, if you're in a high-risk region, it's most men 65 and older would be having this target of 55 milligrams per deciliter. So it's a lot of people, and pretty soon they'll have a new tool to treat it.
Yeah. So are they going to give all these people PCSK9 inhibitors? Because what else is going to get you that low?
That's right.
Yeah. Wow.
Now, well, there are other things. There's other lipid-lowering drugs coming along, like bempedoic acid. But yeah,
still. And where do they get the data? Because the clinical trials, I guess Europe has all this terrific registry data, but the clinical trials have eliminated people that age for so long that we just seem like we're seeing these studies come out one after another saying, yeah, in the elderly, you do have to give them statins. And they don't want to, but you do have to give them statins. So I see just a big divergence in I guess, the data between this, what you're saying, where they collected the data for this, and where in the United States we're thinking, well, yeah, you're 75 years old, you really should be taking a statin. We have the information now. But to go from that to that kind of goal for someone who thinks they're healthy. My blood pressure's okay, my cholesterol's okay, and you're telling me I have to take a $14,000 a year drug? Not that it's that expensive over here, but...
Well, they might be telling you next year you got to get a shot twice a year.
Exactly. Yeah. Yeah. It's all the grand plan.
Which hopefully would be paid for by whoever covers your medical costs.
Exactly. It's so different.
So, Mitch, if this new class gets approved in the United States based on these, surrogate outcomes, as it likely will, do you think it will initially be rolled out as the PCSK9 inhibitors were for people with familial hypercholesterolemia and these other risk factors initially, and what do you think reimbursement will look like?
Somebody actually during a press conference about inclisiran asked about pricing, and there was a representative. It's made by a company, the Medicines Company, and somebody from that organization was there, and they were extremely non-committal on what the price might be. My guess is they're going to charge as much as they can get away with, and
maybe
so we'll see.
Match the PCSK9.
I wouldn't be surprised. Often that's how it works.
Mm-hmm. Which are now, I think, half or less what they were.
Of course, having more competition will perhaps over time drive the price down a bit, and maybe if there's a much larger population of people getting the drug, they'll have some level of benevolence and say, well, we're making so much money we can lower the price, but don't hold your breath.
Well, especially when they negotiate with payers, national health insurance or HMOs in our country. I mean, that's the way the back and forth goes. And when you talk about a super aggressive target like 55 milligrams per deciliter.
Well, the thing is, though, that especially from the PCSK9 studies, I've seen these graphs produced where it's just a straight downward slope. The lower the LDL, the better. And I was actually talking to one cardiologist yesterday about this, and he said he has plenty of patients in his practice now who have LDLs of 20 and 30, and they're doing fine. Sure. And he's happy with it, that they're at that point.
Well, I would like to talk briefly about a study of a much more modest lipid-lowering agent in terms of its potency, but one that's quite popular, red yeast rice supplements. There was a systematic review and meta-analysis of randomized trials done by this group, the International Lipid Expert Panel, a couple of names of which I recognize, and the presenter, who was a lipidologist from Poland, was irate because the FDA recently had put out some kind of a warning, and he was irate because he had done a randomized trial showing that red yeast rice was safe and effective. So he and the other people on this international expert group did a meta-analysis of 52 randomized trials, 8,500 plus subjects, and they found that in some, the red yeast rice was not associated with any increased risk of musculoskeletal adverse events, which is the big concern with statins, and the FDA is concerned with this, and especially something like rhabdomyolysis. And in fact, they found a reduced risk of other adverse events that was significant, a 41% reduction in other adverse events that they looked at. And they found that it was stepwise. So the higher dose you were on, the lower your risk of non-musculoskeletal side effects, and that it was very well tolerated. And they said basically the FDA is full of it, and it is very popular. And he uses it often in patients that are already on a statin to get some extra lipid lowering. I don't think it's profound, but it's a second drug, and it's not a statin, and very well tolerated. So I thought that was interesting. I've got one I'd like to talk about on secondary prevention, if we could.
Sure.
Emil Hagström from Uppsala University did a presentation analysis of data from Swedheart, which is this great Swedish national registry of everybody who has an MI in that country. And This was a study that really highlighted the core importance of lifestyle factors in secondary prevention, something that cardiologists, busy cardiologists, especially if they're interventionalists, don't really pay that much attention to many times. But they looked at 6 major risk factors, lifestyle risk factors, and their impact on prognosis. Blood pressure, current smoking, obesity, fasting blood glucose, LDL, and physical inactivity. And everybody gets referred 6 to 10 weeks after their MI to a cardiac rehab program, and that's when they did the risk factor analysis. And then they were followed for 10 to 12 years after that. And there was a stepwise increase in risk of all the major adverse outcomes with each of these 6 risk factors that was not to goal. So if your LDL 6 to 10 weeks post-MI was not 70 or less, then there's one right there. And the strongest predictors of future bad outcomes, MI, stroke, cardiovascular mortality, all-cause mortality, heart failure hospitalization, and major bleeding, especially an issue early on after a big MI. The strongest risk predictors were physical inactivity, meaning not doing at least 30 minutes of moderate intensity activity at least 5 days a week, and current smoking. And the weakest were elevated LDL and obesity. And for those who got it together and 10 weeks post-MI had none of those 6 risk factors present, they had the same risk of all those major adverse events as matched controls who hadn't had an MI through 10 to 12 years of follow-up. And this was a huge study. This was 65,000 MI patients and 325,000 age and sex-matched controls. And the criticism was raised that, well, yeah, you measured it 10 weeks after, but people can change. And his response to that was 65,000 patients. And I thought that was really impressive. And it's a great message, I think, for patients to try and do something positive, and it will pay off.
And that concludes part 2 of our special Reporters Roundup edition of the CardioCast by MDedge. For MDedge, I'm Nick Andrews.